Hey, so I'm getting into kind of a new area, and I posted a comment on X a week or so, maybe earlier this week into last week, and somebody had a question about kind of whey protein and a recommendation. So I wanted to address that question with one of the comments that I made in that tweet about cancer treatment and nutritional aspects of enhancing the outcomes. So here's a study. So to kind of help address that, the question that was asked was the type of whey. It doesn't really get I don't know if there's much data that is that specific about recommending types of whey yet for cancer, but this study kind of gets at least initially, the issues with that can present with surgery and post-surgery complications for cancer patients. And so this is just one study. It is a systematic review, meta-analysis, and so that's a reason I wanted to include it. And so one aspect you'll note is in one of the limitations, this is a multi-center trial and it's international, so kind of keep that in mind. So while the paper was published out of India, it's not just Indian cancer patients or data. I think most were from Canada, actually. So bear that in mind. So just from an initial issue, and I think some people know, I think those that are in the nutrition realm can appreciate this. Those of you that are just entering the cancer community, welcome. I've learned a lot the past 3 years about this since my diagnosis, so and surgery and treatments, etc. So that's a reason I'm kind of venturing in this cancer area. I've never published in cancer research journals before, but I should have 2 coming out later this year, I hope. So anyway, kind of bear that in mind. So there's evidence that at least over 60% of cancer patients that report for surgeries are malnourished, and with that, that's due to cachexia, anorexia, and especially so. This paper's specifically focusing on cancers of the thoracic region, abdominal region, esophagus, and head and neck. And so for example, does not include prostate, does not include skin cancers, surgeries for other, like, have a dear friend who is fighting bloodborne cancers and is undergoing surgeries due to the deterioration of joints, etc., due to the cancer and treatments they're in. And so while it could be recommended and there could be positive outcomes, these data don't apply to that. So it's mainly colorectal cancer, esophageal cancer, abdominal cancer, head and neck cancer, potentially brain cancer, which is what I have. And so anyway, one issue is when patients with cancer are waiting for surgery, they could become sarcopenic, which is in this case, a cancer-inducing loss of lean mass, skeletal muscle mass. And so that's the concern. And one of the issues is protein is a cornerstone in treating those cancers or those conditions. And so that's what this study is trying to get at. And so specifically they're interested in whey protein due to the high leucine content. However, when we get to the end, there were some issues in that just because of the studies that have been done to date. So studies were from 2010 to 2020. So if there are data out there that are outside that range, they're not included in this paper. So bear that in mind. And so this goes back to for systematic review and meta-analyses, you have to set guidelines on what you're going to include and exclude. Those were the dates they chose for inclusion and exclusion. Sometimes there's a reason. So usually on the later date, July 2020, is you have to pick an end time, because otherwise you'll never get done. Because there may be a study that comes out, right? You're ready to submit, and all of a sudden, oh, here's another study that shows that did this. Let's include it. And then you have to rewrite. And so in order to get something out, you have to put an end date on it. The start date, here they chose, in essence, 10 years. It's one of the issues for, at least with medical issues, is picking a date in which the treatments will be probably relatively similar. I mean, if you go back to 1980, for example, the treatments and surgeries would likely have more complications, and the technology, etc., would be different than it is in this decade. So that's just an example of why somebody might choose a narrower time frame. So no children, all adults. Any nutritional status, they had to have at least one group that had whey protein supplementation in the preoperative period. And even if the trial had whey as an ingredient of any nutritional supplement, it was included. Non-randomized trials, retrospective studies, and abstracts, other sources of information were not included. That again is something you have to say just to limit things. For interventions, intervention group was defined as a group that received whey as the supplement. If there are two groups, so maybe there's a high and low whey intake, the group that had the most whey was deemed the intervention group. You have to do this for the odds ratios, for the statistics of the meta-analyses. Control group included either non-whey protein supplementation or no nutritional supplementation, or routine dietary advice to have high protein diet, which may include egg, soy, etc. It could include whey, but in a lesser quantity. The outcomes were postoperative complications. That was the primary outcome. Secondary outcomes were 6-minute walk test. We'll talk more about that later. Before and after. Before and after. So it's the before was kind of to see if there's some benefit of the preoperative intake of protein, and then the after, you're comparing the post-operative effects of the protein intake. And some of the studies did ingest for up to 4 weeks post-surgery. Length of stay was another one. And then they did subgroup analyses. Oh, and then 30-day readmission. And they did subgroup analyses of whey-only supplementation, as well as pre-operative supplementation. And so there were 4 or 5 studies that specifically address those things, and so that's a subgroup analysis. So here's your description of where they derived their studies. PubMed, Cochrane, Wiley, clinicaltrials.gov. They should have, that's a website, so that should probably be, it's not a sentence and it says it in there, but the clinicaltrials.gov is where you would go, and studies are now required to be registered, at least I think almost all journals now require a clinical trial to be registered and accepted by a clinical trial site. It doesn't necessarily need to be clinical trials, but that's kind of one that is used primarily. Prisma was the flowchart. So here's basically, if you haven't seen one of these, let me shrink this a bit, get that in there. This is a Prisma. So you identify, so they started out with 8,300 studies in the initial fishing expedition, decreased it by almost half, almost half, when they removed duplicates, and then they were further screened to reduce it to 1,000, and then some were excluded because they didn't meet the criteria. For those that met the criteria, there were 59, and so they read full text articles of 59 studies that pertained to this general area. Of those, 51 were excluded, so some were non-cancer. Medical management, so it could have been pharmaceutical approaches or other issues that they used either during surgery or after surgery. Protocol only, non-whey supplement. It'd be interesting to see what those were, just to have that, and no supplements. And so they ended up with 8 on Medline and 2 additional on Central. PubMed Central. And then overall, 10 studies were included in the analysis. So that, just to give you an idea of how that flows. So it started at 8,000, ended up with 10. That's why some of these things, you may not see a systematic review for some things. Doing a scoping review right now, and there were no studies that came up for the criteria that we had listed as what we were interested in. And that will be the first or second, I hope, study that gets published and talk about that. I mean, that's more a procedural paper, but anyway. With these, there's a risk of bias. We'll briefly review that. There's subgroup analyses, which we talked about for Whey only and timing. Results are here. So one of the things that's interesting, so with these, they sum up all the patients. So there were 657 patients with basically 330, almost half, about half in the intervention group and about half in the control groups. Baseline parameters for both groups were similar, so that's a good thing for bias and validity perspectives. Post-operative complications, Clavien-Dindo classifications, that's a grading scale that is used to, so if there's some sort of thing that has to be resolved during surgery, the worst, obviously, which is unresolvable, is death of the patient. But it can range from we needed to give more anesthesia or more something during surgery that's maybe a medicinal approach to surgical, oh, we have to address this before we close up. Something happened that wasn't expected, and so it just ranges from a grade 1 to a grade 5. And some elucidated postoperative complication events such as infection, pneumonia, surgical site infection, or ileus. In essence, from the results perspective, the use of protein, whey protein, not necessarily whey only, but whey protein supplements as part of their diet resulted in 22% of the intervention group experiencing postoperative complications and 32% of the control group, which is an odds ratio of 0.61, and which was significant. So confidence interval 0.41 to 0.90, below 1, 0.0, and so 0.01 as far as the p-value, the probability. We'll get to the four spots here in a second. Subgroup analyses, no difference. And so one of the issues we'll talk about is sample size, statistical power, those types of things, and that's kind of one of the limitations of these subgroups. There just weren't enough. And what you'll see here, for the interventions, most of the studies used at least 1.2 grams per kilogram protein per body weight per day. So that's kind of what we're, at the end, the summary is going to be recommending that. And here's one that's like 18 grams away 12 hours before. So some of them did not necessarily do that, but many did. And from a dietary recommendation, that seems to be kind of where people would probably recommend. That's current kind of recommendations for most people. We can debate the RDA for protein or discuss it. I don't really want to get into a debate about it, but I am on the side, having done some protein work with Dr. Wayne Campbell back in the day, leaning towards this higher intake than the 0.8, and I think the data are there that it'll do more good than potential harm. The benefits outweigh the risks, just for most people. Granted, there could be some issues with types of protein. Let's talk for a different day. So some of the subgroups are here. Or secondary analyses, sorry, this is secondary analyses. And looking at the 6-minute walk test, length of stay, 30-day readmits. So the only one that was different was the 6-minute walk test, with both the prior protein intake pre-treatment enhancing or increasing the walk distance before surgery, and then 4 weeks after surgery. The p-value, we'll talk about this in a minute, but the p-value 0.02, 0.4. So this is the distance, how much further they walked in the whey protein group. Basically 24 meters longer versus 46 meters longer in that 6-minute time frame. So it's not the total distance, but how much further the treatment group went. Length of hospital stay is not significantly different. And this is a force plot, and so one thing to look for is the bottom part here, where it describes which is favored as far as risk. These are risks. It does not mean that if you ingest whey protein, you will not have complications. It's just you will have a reduced risk of those complications. So if you go back looking at the 22 versus 32%, 22% of the people who ingested whey protein still did get complications, but it's fewer. So there were 30-ish people. I think the math's right. 30 or 60, 10% difference of the people got complications versus the control group. And I probably didn't do the math right there. I'm thinking on the fly. I should have done that math before I did this. Anyway, 6-minute walk test, talked about that. We'll talk about the issues with the sub-analysis here in a minute. And so here's the walk test data. And so just to go over a force plot, one thing I look for in force plots is how many studies were significant as standalone studies. And so for this one, I gotta look at this one really close. It doesn't say. Oh, it's 0. Oh, it's pretty close. Okay, okay. Yeah, so this was different. So there's 3 studies that showed significant difference here, and 3 that did not. So half the studies were significant before they did a meta-analysis. And I looked for that. So sometimes what you may see is the diamond. This shows overall significance. May still be here, but there may be all the dots may be right in a line, and none of the studies individually may show a significant outcome. And that kind of concerns me when there are no studies that show significance by themselves, yet you pool them together, and the effect of a larger sample size pushes it into a significant effect. Now, from a clinical perspective, I may not have a problem with that. Just from a pure statistics perspective, those are some of the issues I have with meta-analyses and force plots and odds ratios. But that's more of a class issue that because I teach these things in class to discuss in a purist perspective, and necessarily what do we do with these data from this study. So same thing here. 2 more significant versus 3. The overall effect is still there, and then favors whey, favors control overall. For length of stay, there's one study here that's really variable, and so that can kind of pull things depending upon other aspects, but so that was a significantly reduced length of stay for that one. But anyway, overall, no difference. It was close. I mean, theoretically, it was kind of close, but minimal effect, I guess. So this would be the example of a risk of bias. And so what you have to do if you're going to do a systematic review and meta-analysis is go through. There's certain questions that are going to be asked depending upon the type of studies and those types of things. But the graph D1 through D7 are listed here, the questions that they addressed. And they went through, based on their assessment of each of the studies, they went through and gave a plus, a minus, or an X. So strong, moderate, or weak issue with so there's some methodological issue with, or not, with some of these. And so one of them, from random sequence generation, so were they randomly assigned? Yes or no? There's one study that might not have been. There may have been some quasi-random things going on. Allocation concealment. And so one study, they didn't conceal, so they knew. And so that's blinding. And so if somebody knows what they're getting, that may affect outcomes of either the research team, the clinician, or the patients. And blinding of participants and personnel, staff, so nurses, whatever, that may be also involved, and then on out. And so, other sources of bias, there were concerns, and most of the time for these, it may not be stated, and so it's an I don't know. But this one study seemed to have reported all that they felt were pertinent, so they gave them a plus. And so you won't see a study that gets really all greens on much of this, especially for a clinical study, just because there's usually things that happen with patients, with their care, with the season, whatever, that is like, oh, you can't really control some things, and so kind of bear that in mind. So this is actually pretty good, pretty average, I would say, for a lot of studies. Actually, usually there's some more reds with some studies. So post-operative complications, we reported 30-day readmission. It was a lower number, but not significantly different. So this gets into the issue of clinical relevance, and so maybe it's not statistically relevant, but maybe it's clinically relevant. So I mean, 10% versus 13%. Strengths. It's the first meta-analysis evaluating effect of whey protein, and so they did have 14 studies that didn't use whey. It'd be interesting to compare these 10 to those 14. Somebody can do that later if you want. Limitations. One is only 10 trials, and so this addresses a lot of things. So only 600, less than 700 patients. The subgrouping, there were 4 or 5 of those studies, and so I think they were underpowered for trying to find a difference. And so if you have 10 studies, if you do a couple more studies, some of those would likely be different just from a sample size. So going back to the issue that I talked about with the forest plots, the small sample size can affect probability, and so just increasing sample size tends to lead to a lower p-value or increased probability of finding a difference. Location bias. So also for the 6-minute walk test, there were some missing data. So there were some imputations, which is basically you're trying to figure out a way. So there's missing data. How do you handle that? And so there are ways to do that. They used a way. They described it. So we can debate whether that was the appropriate way to do it, but it is kind of acceptable. But sometimes when you don't use real data, you derive a data point, it can lead to bias with the formula. So just bear that in mind. Limitations of the trials. Exclusive post-operative supplementation of whey was performed only in one trial, and so that's the issue that I come back to. The title is somewhat deceiving because there was only one trial that used exclusively whey, and so that's kind of a complication. So coming back to kind of my summary on this is my takeaway is, for those of you that are preparing for cancer treatment, this type of cancer treatment, I don't know if other types of bone marrow, bone cancers, whatever, and those surgeries would fall under the same criteria as these studies. But if it's colorectal, esophageal, stomach, head or neck, basically the studies that were used here, or you're caring for somebody who is getting ready to go, I would kind of recommend eating at least 1.2 grams per kilogram body weight per day. It seems to decrease post-operative complications. It won't prevent it. That is, it won't be 0% for a group. But if it decreases your risk, and maybe it decreases the severity, and so from the grading of the severity, maybe it's a 2 instead of a 3, which benefit. So maybe lessen the severity of the complications as well, even though I didn't study it. But so what does that mean? For somebody who's 130 pounds, that would be at least 72 grams of protein. For somebody that's 175 pounds, it would be eating at least 96 grams of protein per day. And for those over at 220, it would mean eating 120 grams per day. Basically, you need to take your weight, since in the American system we use pounds typically, and so convert that to kilograms. Basically, divide your weight by 2.2, and then find out 1.2, 1.5, and kind of go that route. And so I think it's a good goal anyway. So even after treatment, after you get through things, if you're not eating that, maybe strive to eat that amount. Anyway, so some of the other aspects why this can be important are, for example, my surgery. I went into surgery, I prepped, so I didn't eat anything. I gotta look back, but I think I was told 12 hours before surgery. I could be wrong. Could have been midnight, anything after midnight, or water after midnight, nothing after midnight. Maybe no food after 6, 24 hours before. Went in to the operating room about 6, and then woke up post ICU at about 11 p.m. So I was not eating for at least 23 hours. I think I had ice chips and maybe the wet sponge for a few hours till morning, and then I think I was allowed to have a 7-Up or Sprite, whatever they served at the hospital, until breakfast, and then at breakfast I was able to consume foods again. So that's an example of how long somebody can go without food. Now, obviously they're going to be using amino acids and other type of nutrition through the IVs, and so hopefully you got some good computations going on there to make sure that the fuel levels are adequate, and I think most surgical teams are well adept at that, so I don't see that being a concern. But from a food perspective, I think that's one issue. And so also, in making those choices upon admission to the hospital for the however many days you're going to be in the hospital, making sure to choose protein foods and maybe consult a dietitian to help make those decisions. I would think that would be definitely suitable and definitely something that would be recommended, and they could also help with other recommendations from an oncology perspective or a general health perspective. So anyway, I hope you found that helpful. I know it was probably kind of long, but I just wanted to kind of go through an initial cancer paper and help address a question that was raised on X to somebody that was asking. So hopefully this will help that person and might help you too. Thank you.